Now the next question. The next question which arises in the mind of a beginner and a person who is seeing probably ECG for the first time, or maybe for all those who have seen it multiple times but they are not having a good core concept. The question arises in their mind that why these lines, even in a normal person, are sometime in certain different directions, they are sometime in certain altogether other directions, although the person is having normal heart, but in different leads, as you would be seeing those waves which make that ECG waveforms. So you see that their dimensions, directions are different. So how we will draw these 12 ECG leads in a normal person, this is now you are going to understand in next 5 minutes, and that will be the basically end of that major basic ECG session. Onwards, then I will be having a little bit of questioning, answering, and kind of a workshop. So the point is, we need to draw these 12 leads. Why these leads look different? Based on this whole circle, this whole idea, it will be so easy for us. Before I jump to this point, I just want to highlight about these waveforms. If ever somebody asks you a question that what ECG would you love most so that you can interpret it well in your exam, so everybody would love to have that ECG, that good line. So that good line will clearly tell us that heart is no more there. So is there something more difficult to interpret? Easy to interpret, right? So this is the easiest interpretation. But luckily, that person turned out to be a Tamil movie hero. And as the heroine just shouted loudly that I want you back in this world, his heart started flying from Mumbai. The doctors had opened the chest wall and they were doing the cardiothoracic major operation. The heart ultimately jumped back to that thorax again. You must have seen this on YouTube, fine. So that's the only thing you guys know very well. So that heart jumped ultimately in that thoracic cavity and started pumping again, and then you guys were in trouble because now it is producing certain lines. So see these lines now. So how these things happen in human beings? The first thing is you need to understand about the conduction system. There is a very simple conduction. I have told you one thing right at the start, and that was heart has got the intrinsic ability to generate electric current. You're not supplying it from some pole. You're not attaching a human being with a certain pole of electricity. Rather, the heart is producing it itself. So you know about the conduction system. Here, there is SA node. From its SA node, the current goes to AV node, and then there is bundle of phase, and that bundle of phase is having right bundle towards right side, left bundle towards left side, and that bundle divided into two fascicles. One is known as left anterior fascicle and one is known as left posterior fascicle. So the thing is SA node to AV node bundle of phase, right bundle, right side, right bundle, left side, left bundle, left anterior fascicle, left posterior fascicle, and then ultimately it goes in the Purkinje fibers, and this is how current distributes in the whole heart. How these things happen on that ECG paper. As heart starts beating, the first wave which is formed in a normal person is known as P wave. What it is interpreting? It is interpreting atrial contraction. The two atria work together, contract at the same time, and form ultimately this lead. So basically what is happening in the heart? There is atrial depolarization leading to contraction of both atria. These are small size. So there is a small deflection on that ECG paper. These are small size. Understand this good concept. Small size, so small deflection. This is atrial depolarization wave. What is happening next? The current is going from SA node to AV node, and during that process the atrias are contracting. And this is the waveform. Then what happens next? This current go in the septum. And then there will be atrial, after atrial depolarization there will be septal depolarization, and there is a small wave formulation known as Q wave. So one is P wave, one is, you just name these waves as anything. So these have been named as PQ, so just you need to understand it. So this has been named randomly. So this is P wave, this is septal depolarization Q wave. Then what is happening next? Then this current from septums is ultimately through the bundles, both bundles, going ultimately to the Purkinje fiber and leading to the contraction of big size ventricles. So as these are big size ventricle, deflection is also big, and you see this wave, and this is known as R wave. As this wave comes back to the baseline, we call it S wave, and as this ventricle depolarization is there, ultimately all these things which depolarize, the channels open, sodium, potassium, you understand about those channels, the calcium influx and all those things. So these channels open, depolarization is done, ultimately they repolarize. So then there is ventricular repolarization, and this is known as T wave. This is what happens in normal human beings. And you should have, like, one can ask this question, that the way this ventricle is repolarizing, the same way the atria and the same way the septum should also repolarize, and that, yes, they do repolarize. But as soon as they are going to form that repolarization wave exactly on the same time, the ventricle form the big depolarization wave, and they are basically hidden or masked inside that depolarization wave. So basically they do repolarize. This is all masked inside. That's the total picture. But why that picture is different in different leads, this is what I am going to tell you. And before that, another important thing, on ECG waveform, there was a straight line when there was no current production. And then as heart started beating, you found those lines. Why these lines are formed? These lines are formed, recall physics. If you recall physics, you will recall that current is being dissipated from the human body. This is electric current. The stylus, the fine instrument that moves on that ECG paper, it needs some energy to form this thing. It needs some energy to move. So this energy, it is carrying through that electric current which has been offered by the heart. And the work which it is performing is mechanical work. So it's a mechanical work, which is mechanical kaam kar raha hai, wo mehnat kar raha hai. So it's the mechanical work which it is doing. And the waveform, which is the things, the waves which it form on the paper, are the thermal waves. So what is happening here? Electrical energy is being converted to mechanical energy, is being converted to thermal energy. And you see this waveform. And if somebody asks this question, that how is it happening? So it's as simple as that. As per rules of physics, one form of energy can be converted to another form of energy. So it's as simple as that, right? So electrical energy is being converted to mechanical energy, is being converted to thermal waves here on that paper. Now I am drawing these 12 leads. Why do they look different? So lead 1, lead 2, lead 3. First I draw these 6 limb leads, and onwards it will be so easy that you can comfortably draw the rest of chest leads as well. This is the normal ECG which you would be seeing in a normal person. Rule number 1, as per rules of physics, again recall physics. I already told you that current is being dissipated to all directions. Recall the rule of vectors in physics, downward. If you see this thing on right chambers, on the right side, the muscle mass of right ventricle is lesser in comparison with muscle mass of left ventricle on the left side. So if we see that in which direction it should deflect, it would be deflecting in that direction which is having more muscle mass. So ultimately the current which is being dissipated from that position is going to all the directions, but summing up, the maximum amount or strength of current will be in that direction based on the big size ventricle. If in certain people they are having a disease, say pulmonary hypertension, what it will lead to? It will lead to the right ventricular enlargement. The right ventricular muscle mass will increase, As it will increase, this direction of current will be to this direction. If it has increased more than the LV side, and that is why we say, okay, this gentleman is having right ventricular hypertrophy and his axis is right axis. That's the reason. So it's a simple logic. So that is why this is in that direction. So this is the direction of normal cardiac axis in humans. Normal cardiac axis, this is the direction. Actually, this vary from this has got this normal cardiac axis has got a big range. So from minus 30 degree to 110 degree, wherever this axis falls, in all that area, wherever that axis fall, we call it the range of normal cardiac axis. Why I am telling about this thing to you guys? This is because I am going to draw these 12 leads now, and this is all based on this single principle. The flow of current, the maximum flow of current is in this direction. This is the normal cardiac axis. Now, if, remember this sentence, memorize this sentence. If the direction of flow of current in a human being, if a direction of flow of current is towards that normal cardiac axis, the deflection produced by that stylus over that ECG paper will all be positive. In other words, will be above the baseline. Again, remember this sentence. If the direction of flow of current is towards the normal cardiac axis, the deflection produced by that stylus will all be positive. Now, if I ask you this question, that out of these 6 limb lead, which limb lead is almost having direction exactly towards this cardiac axis? That is lead number 2. So if you see the lead number 2, the deflection is like that. As simple as that. P wave above the baseline, QRS above the baseline, P wave above the baseline, all deflection positive. Now I ask you another question. Just see this whole illustration, see these degrees. Tell me the name of the lead which is showing deflection or which is having direction exactly opposite to it. That is AVR. So how AVR would look like? AVR all negative. So now you come to know that why in ECG when you see this AVR, this is all negative. So that was the simple interpretation. The deflection of flow of current, direction of flow of current towards that axis, all will be positive. Away from that axis, all will be negative. If certain situation arises, this person is having right ventricular hypertrophy, the direction of flow of current will be here in this direction, because this is the area of a normal axis. Then if it goes beyond that area, we call it right axis. If it goes beyond that area, we call it left axis. Say in a person, now the axis has been changed and it is exactly directing towards this area. Now tell me in which lead the deflection will all be positive. If say in a person the axis has been directed towards this lead number 3. 3 is here, no? So 3 will be all positive. And which will be negative? This one. Exactly, see opposite to it. In a circle, there are 360 degrees. And if something is exactly opposite to something, it would be 180 degree away from it, right? If something is in this direction, this is AVR is almost in opposite direction, almost. So that is why it is showing deflection, negative deflection. Here, the situation has changed. Now the axis is to this position because of the hypertrophy of this ventricle or some other reason. Now the negative one will be this one and positive one will be this one. So you must be having a real good concept. So that's basically the story behind it. Now tell me the name of another lead. Tell me the name of another lead which is very near to this normal cardiac axis lead. So that lead would be almost giving the same picture. This is at 60 degree, this is 90 degree. Nearest to this lead. So the deflections are almost similar in AVF. So AVF, you will also see the AVF picture almost the same way. But here, above the baseline and slightly below the baseline, because it is not in exact direction but very close. So I am just drawing it a little bit underneath the baseline as well. This is the baseline. This is the baseline. This is the baseline. Now tell me, a lead in this whole picture which is falling right in the center. Neither it is exactly away from it like AVR, nor it is very close to it. There is one lead which is falling right in the center, and try to again try to calculate in mathematical terms. If something will be exactly opposite, it will be 180 degree away. So is there some lead which is almost 90 degree away from it? From this point to this point, 60 degrees. From this point to this point, exactly 90 degree. Which lead it is? AVL. So AVL is falling right in the center. How it should look like? That's the point. Almost it will be half above the baseline, half below the baseline. As simple as that. So depending on the axis, if that person's axis has been to this direction, has been changed to this direction, when in this situation, it will be all negative, but the axis is, I am discussing normal axis. So in that scenario, this is falling, this looks like half QRS above the baseline, half QRS below the baseline. So that was the simple logic. Now tell me the name of the two other limb leads which are more close, less away. I have already told you, if something is exactly opposite, 180 degree. If something is as negative as positive, falling right in the center, that is 90 degree. Now can you tell me the name of the two limb leads, and use common sense? Name of the two limb leads which are more close and less far from that two. Actually there are only two leads left. So nothing more to add. Both this lead 3 and lead 0, they are 60 degree away, right? So they are relatively near, not far, relatively near. So in both these leads, should that QRS be more above the baseline? Answer is yes. Relatively more above the baseline and less below the baseline. AVL, half above the baseline, half below the baseline. AVR, exactly opposite to it. That's the whole story behind that ECG basics. We were just seeing a human being where we were placing these electrodes, and this is how we interpret all these things. For a beginner, and now the 6 chest leads, and we'll finish here. In 6 chest leads, as I have drawn these leads, thing is very simple. I have placed these, I have told you that how to place these chest leads. If you ask me this question, that which lead among these 6 chest leads is exactly in the direction of cardiac axis, that is lead V6. So in V6, in which of these leads out of these 6 chest leads, which of the lead would be having nearly all positive? V6. So while drawing these leads, V1, V2, V3, V4, V5 and V6, very simple. V6 all positive, just like lead number 2. V5 almost positive, a little bit of negative deflection. V4 more positive, slightly less negative. V3 almost half positive, half negative. V2 less positive, more negative. V1 almost all negative, even the lead T wave is also negative. So this is how you draw these 12 leads in a normal person. Take home messages are basically 3 to 4 things are very important up till now. The first one, the most important one, lead is like a camera. This message should always be in your mind, because whenever somebody will be asking you a certain question, that camera thing will come in your mind. Okay, gentlemen, now if I want to ask you, I am seeing this patient and having a suspicion he is having right ventricular infarction. Which leads you would be focusing on? RV4, RV5. So you need to get his additional ECG done. You would be adding right-sided ECG in that person as well. And why I would be thinking, this last thing I would like to tell you before we just close this session, why I would be thinking in a certain person that his right-sided ECG should also be done. Before understanding this thing, the final concept in 1 minute, because this is the most important thing you guys need to know, and that is, you need to know what is the blood supply. If ever somebody asks you a question, ECG is important in many medical conditions. If somebody asks you the question, the most important among those medical conditions is in relation to ischemic heart disease. This should always be in your mind. The world's biggest reason of mortality is cardiovascular diseases. So ECG is such a good guide about these ischemic heart disease states. Here the heart is. From this part, there is artery known as coronary arteries, obviously, main stem. And that main stem is then left anterior descending artery. And then there is circumflex artery, right? There are two splices. One is right coronary and the other one is main stem or left coronaries. So then there is right coronary artery, RCA, we call it RCA. This is main stem and we call it left anterior descending artery, we call it circumflex. And then this RCA, in 80% of patient, this RCA give branch, posterior branch. So RCA give posterior branch in 80% of patients. And this circumflex supply give the posterior artery in rest of 20%. So in certain patients, if they would be having circumflex artery infarction, there is a blockage of the circumflex artery. Which part it supply? Just see where it is. Lateral wall. Which wall this LAD is supplying? Anteroseptal wall. Which wall this right coronary artery is supplying? Right ventricular wall as well as inferior wall. And 80% posterior wall. In a certain person, if his circ gets blocked, you find that there is significant ST elevation in lead number V1, 1 AVL, V5, V6. What it will guide you? You are seeing on ECG, and immediately onwards after seeing ECG, you said, well, gentlemen, I am having a strong suspicion this gentleman's circumflex artery has been blocked, and besides that, his posterior artery has also been blocked. His posterior wall has also been damaged. That will be the thing in your mind. Then you would call it that this person is actually having circ dominant. What does it mean? It means that this is among those 20% where that circ was supplying the posterior wall. Because with the blockage of that circumflex artery, you also find changes in his posterior wall. So if these two changes are there, it means the circumflex artery is supplying the posterior wall. Situation number 2, a person is having right ventricular infarction and besides that also having posterior wall infarction. It means right coronary artery dominant. So you speak the word right coronary artery dominant where right coronary is supplying the posterior wall, circ dominant where a person is having circ supplying the posterior wall, and inferior is obviously supplied by the right coronary, and the rest is anterior wall, septal wall. This is supplied by the left anterior descending artery. Now if I block left main stem, what will happen? So that you would be having good interpretation. I am blocking left main stem before it is bifurcating into two vessels, circumflex and left anterior descending. So how much damage will be there? Lateral wall gone, his anteroseptal wall gone, and if that circ was supplying in 20%, that will all be gone. So that's the simple answer. That's how the cardiologist, after seeing that ECG, immediately tells you, well, gentlemen, I'm having a suspicion this gentleman is having infarction of his anteroseptal wall, infarction of his lateral wall, infarction of his, on ECG you would see it like that. On ECG you would see that his one AVL V5 V6 gone, his V1 V2 V3 V4 showing ST segment elevation, posterior wall V1 V2 is also showing ST depression. Mirror image you would be seeing ST depression, and mirror image would be telling you that it is basically ST elevation. So you need to understand this thing as well, right? You need to understand the blood supplies as well. At the end of the day, we need something practical. So that is the practical answer to whatever we have read till now. So take home messages. Message number one. Message number one, lead is like a camera. Message number two, walls of heart. 5 different walls of heart are represented by different leads. You need to memorize these leads. Number three is you need to understand, and you should develop a good understanding how to draw this circle. Where are these different angle degrees, and see how helpful these are. I have told you clearly that how helpful these cameras are, these leads are. And finally, drawing these 12 leads would give you a real good picture that why in normal humans these leads vary from one person to another person. Different leads have different kind of picture, and it is all based on one single fact, that whatever the direction of cardiac axis is, the whole ECG picture will be based on that particular thing. So if you ever read ECG, the main thing which you will be focusing on before you interpret the ECG will be that you would be seeing the axis first. All leads will be changed upside down. You need to see, is that person having the normal axis, or his axis has been shifted to right, or axis has been shifted to left. Everything else will change, because all these angle degrees will all be changed if somebody's axis is in this position, say. Now this AVR will be all positive. This too will be all negative. Somebody is having extreme left axis here. The axis has gone to that point. Then his lead AVL will be all positive. His lead 3 will be all negative. Now this lead will be falling in the center. So one change, the whole 12 lead changes. This thing you guys need to understand. So we finish our session here. Any question, any queries on your part? लीड 3 और लीड 1 में देखें, आपने उससे तो काउंट करने की जरूरत ही नहीं कि उनका आपस में कितना है, आपने तो नॉर्मल कार्डिक एक्सिस से देखना है कितना है. तो इसका डिस्टेंस मेजर करें इनके दरमियान, यानी इससे 60 डिग्री अवे है लीड 1 और इसी लीड 2 से 60 डिग्री अवे है लीड 3. आपस का डिफरेंस वैसे अगर कोई भी पूछना चाहे वो तो मैथमेटिक्स है कि इधर से इधर कितना फासला है, उधर से इधर से भालपुर का कितना है, उधर से अहमदपुर का कितना है, उधर से लोधरा का कितना है. दैट्स ऑल टुगेदर अ सेपरेट क्वेश्चन. जी मैं ले लेता हूं. और एनीथिंग एल्स, एनी क्वेश्चन? दैट वाज द मोस्ट इंपॉर्टेंट क्वेश्चन फ्रॉम अ ब्रिलियंट स्टूडेंट. सर ये अटेंडेंस वो मैं लाजमी ले लेता हूं. और कोई चीज?